So let's talk about two types of psychotic disorders. We have the schizophrenia and then we have the delusional disorder. So let us discuss one by one. So when we say psychotic disorders, all right, so when the disorder is considered to be psychotic, take note there are four key classic signs. Number one, there is difficulty in thinking clearly. So there is a cognitive problem. And because of this difficulty, this person will have difficulty making good decisions. So he cannot process the facts available to him. Third, there is this difficulty distinguishing reality from imagination. So the mind is already confused what is real and what is not. And because of this problem in the thinking process, problem in the analysis, problem in the perception, the behavior also becomes inappropriate. So this person will manifest as somebody having difficulty handling his life. Okay? He doesn't know how to take care of himself and he doesn't know how to interact with others. Or if he does, it is malfunctioning or it's not the right way. And so if left untreated, this person can really be a risk of harming oneself and the others. So let us go to one type of psychosis, which is schizophrenia. And this is the most common psych disorder. Okay. Now, um, here you will see that when we say schizophrenia, this is marked by withdrawal from reality. So really the person is not anymore in tune with the reality. Okay? The thoughts are illogical. There is delusion. There is hallucination. And the emotion is disturbed. The behavior is disturbed. The thinking process is disturbed. So all four things: problem in the thought, problem in analysis, problem in perception, problem in behavior. And the fifth thing is this difficulty has been in existence for more than 6 months. Okay, so that makes it already psychosis. There is this difficulty distinguishing reality from fantasy. And because this person behaves differently, he can be a threat. Others can be afraid of him, will really know that he is not your normal person to deal with. Okay. Now, there are different types of disorders, different types of psychotic disorders. But for today, we will just focus on schizophrenia and delusional disorder. Now, you can see here that we have a schizotypal personality disorder, we have brief psychotic disorder, we have delusional disorder, we have this so-called schizophreniform, schizoaffective disorder. We even have a psychosis that is substance abused, and this word psychotic or catatonic disorder, otherwise not specified. So just to quickly look at their definition, but not necessarily to be a master of it, because you need to be a psychiatrist, a long years of study before you can really distinguish the different types of psychotic disorders. So here, schizophrenia is defined as with a client having psychotic thinking or behavior present for at least 6 months, and the areas of functioning, which include school, work, self-care, even interpersonal relationship, are significantly impaired. We also have the schizotypal personality disorder, whereby the person has impairment of personality, which affects now his functioning, although this is not as severe as the schizophrenia. We also have delusional disorder, whereby the client experiences delusional thinking for at least 1 month. So there is self or interpersonal functioning impairment. And then we have brief psychotic disorder, whereby the client has psychotic manifestation that last 1 day to 1 month in duration. Then we have the schizophreniform disorder, wherein the client has manifestations similar to schizophrenia, but the duration is only 1 to 6 months. And the dysfunction socially or in relation to the occupation may not be that apparent. That's why it's only schizophreniform. Then we have the schizoaffective disorder, whereby the client's disorder meets the criteria for both schizophrenia and depressive or bipolar disorder. So it's a mixed personality. Then we have the substance induced psychotic disorder, whereby the client experiences psychosis due to substance intoxication or withdrawal. However, the psychotic manifestations are more severe than typically expected. And last, you have your psychotic or catatonic disorder, which is or not otherwise specified, whereby the client exhibits psychotic features. So, what are those psychotic features? There's impaired reality testing, there is bizarre behavior, you have the impaired motor activity or catatonic. However, all these mark manifestations, since there's more to it than what is written here, the other criteria to be specified as schizophrenia is not complete. That's why it's only termed as um, not otherwise specified. So, in other words, psychosis can be of various form and various degree, and that's something a psychiatrist will have to figure out. Another thing that we have to understand or be aware when we talk about psychiatry or psychosis, the disorder psychosis, is that when we look at signs and symptoms, we categorize this as positive and negative. So when we say positive symptoms, these are manifestations of things that are not normally present, and yet now they are easily manifested. So these are not actually noted before on the person, but now that psychosis had set in, you can really see the change. So an example to these are hallucinations. You can observe that the person have a wrong perception of whatever is in front of him. Or there is a false belief, which is the delusion. And you can observe it in the way he speaks because it will become uh, bizarre, confusing, does not make sense, and not only in speech but also in behavior. So when you say positive symptoms, that is something you can observe that normally you don't really notice it because when a person acts normally, you just presume that's the way a person acts. But people with psychosis, they have these manifestations that you really can say there is something not correct in this person. The opposite to which is negative symptoms. So when we say negative symptoms, there are absence of things that are normally present. So now these manifestations are more difficult to treat successfully than positive symptoms because you don't see it. You expect a certain behavior. The behavior you expect is not there. And in fact, then you wonder what's going on. So one is affect. So the affect here is usually blunted or flat. Okay, a facial expression that never change. Everyone's laughing. This person is just flat. Or alogia. When you say alogia, poverty of thought or speech, wherein the client might sit with a visitor but only mumble or respond vaguely to questions. We also have anergia, which is lack of energy. So, um, depressed. And then anhedonia, lack of pleasure or joy. Now the client is indifferent to things that often makes others happy. He looks at a beautiful scenery and he does not have any expression at all. Or avolition, the lack of motivation in activities and hygiene. So, for example, the client completes an assigned task such as making their bed, but is unable to start the next common chore without prompting. Like there's no initiative. Okay. We also have cognitive findings. When we say cognitive findings, these are problems in the thinking process. And because this person cannot think properly, it will be difficult for this person to live independently. Why? Because first, thinking is disordered. He cannot make decisions. He cannot solve simple problems at hand. He cannot even concentrate performing and completing tasks. There is short-term memory deficit and abstract thinking is markedly impaired. So there is no good, complete thought in order to carry out a certain task. Another manifestation would be those that are involving the emotions. So, hopelessness, suicidal ideation, rapidly changing mood. Okay, so these are all signs of psychosis. So, you have it here an example of these positive symptoms, these negative symptoms affecting now the feeling, the behavior. So the person becomes dysphoric, suicidal, hopeless. And then you can see cognitive wise, this person does not pay attention, poor memory, cannot solve problem, illogical thinking process, poor judgment. And all of this will contribute to the person's failure to complete his work, failure to establish interpersonal relationship, cannot take care of self, cannot function normally in the society, affecting now his quality of life. So that's your psychosis, specifically your schizophrenia. Let us go to delusional disorder. Now remember, delusion is one classic symptom of psychosis, but um, that's schizophrenia as an example of psychosis. But we also have a psychosis that is simply focused on delusion. Okay, and we call this delusional disorder. So we have different types of delusional disorder, but let's describe first. So when we say delusional disorder, this is a psychotic disorder wherein the patient is unable to distinguish what is real from what is imagined. So in other words, it's a false belief which is a product of a faulty interpretation. And just like any psychosis, delusion can be a result of a lot of things. Okay? And then in this case, a person holds false beliefs strongly, even without proof to whatever he's saying. Okay? And the delusion can be bizarre, which is like, this is impossible, or non-bizarre. The things that are possibly, it will exist, um, but it's kind of weird, or you cannot believe based on the background of the person, just such as belief that one is being followed or poisoned. Okay, so according to the DSM-5, which is your Manual of Mental Disorders, a delusional disorder is an illness identified by at least 1 month of delusion, even without the rest of the psychotic symptoms. So, what are the rest of the psychotic symptoms? Hallucination, unable to take care of self. Um, you have the cannot make decisions. Okay, so people with this condition can continue to socialize, function normally, as if there's no unusual, bizarre behavior. Okay, however, They would have false belief within themselves. That's why we call it delusional disorder. Okay? And commonly happen in middle to late life and prevalent in women than in man. So what are these delusional disorder? So we have we'll just pick some example. Delusional jealousy. Okay? This involves feeling where one sexual partner is being unfaithful. There is a preoccupation in the thought that one's partner is having a mistress. Okay? We have erotomania. This otherwise is something really, really weird when one imagines that another person of a higher status is in love with her. Okay? So there is a persistent thought that somebody higher than you loves you. Okay? Like a person. Then we have the delusion of grandeur or grandiose, wherein there is a heightened value, knowledge, or power, special relationship to a famous person. Delusion of being controlled. This is believing that the feelings, impulses, thoughts, or actions are under the control of some external force rather than their own. We have delusion of reference, wherein there is a belief that unrelated events in the outside world have special or unique relevance in one's life. Okay? So, in other words, everything around you is happening because it has relation to you. We have delusion of persecutory. This is a belief that subject or someone close to them is attacked, harassed, deceived, or conspired against. Somebody is always following me or my family, something like that. Delusion of somatic, feeling that the subject is being affected by a physical illness, having some type of physical defect. So when you say soma means body. There's preoccupation of one's body. We have thought broadcasting, whereby the subject believes that their ideas are being broadcasted aloud, causing others to notice them. Or delusion of thought insertion, thinking that thoughts that their thoughts are not their own but is rather inserted by an external force. Or mood congruent psychotic features, having delusions or hallucinations involving typical themes of a depressed or manic mode, and your mood incongruent psychotic features, feelings of personal inadequacy, guilt, death, disease, nihilism, or deserved punishment. So other delusions, I think I mentioned some of them already. We have these ideas of reference or the referential delusion. I think we have the somatic. I think most of it are already um, discussed. We have this magical thinking delusion, the last part. This is a belief that actions or thoughts are able to control a situation or affect or will affect others, such as if I wear a certain hat, I become invisible. So really, really delusional. Okay? We also have alterations in speech. Remember, these are signs of psychosis. So the person will start talking and will really be bizarre, will sound bizarre because there's a lot of bizarreness. So one is associative looseness, wherein there is flight of ideas. The client's speech moves so rapidly from one thought to another. We have neologism. Neo means new. The person is creating new words that he only can understand. We have echolalia. So the client repeats words spoken to them. So if you say, "How are you?" and the client will reply, you. That's echolalia. We have clang association, which is the rhyming of words. So client will talk fast, uses words that rhyme. Fang, sang, bang, lang, kang, rang. Okay, that's rhyming, which is like word salad. So clang association is really word salad, except that there is rhyming. And then we have circumstantiality and tangentiality. These are conversations that, they're just like random conversations, but there's really no focus. Okay. So we also have hallucinations. Remember, what did I say with hallucination? There is a stimuli, but it is misinterpreted. So there is a sound coming out, but then the person thinks somebody's talking to him. Or he sees a candle, but for him, that is more of a spirit, okay? Or he smells something and will interpret it as um, something else, okay? It's not like a interpretation. It's really something beyond what is normal. Tactile, like I feel like there are spiders running around my skin. Okay, so those are alterations of speech that actually tells you there is already psychosis going on. And then there are boundary difficulties. The person cannot figure out who is he and some actress. That's depersonalization. Derealization. He feels like he's in the heaven. Okay, that's derealization. And of course, you have illusion. There is it's similar with your hallucinations. Okay, there's misinterpretation of the real experience. Hallucination is more of a stimuli, while illusion is more of perception of the environment. And then you have your different alterations in behavior. So look at the picture. It is so bizarre that you really can say this is not how a normal person would behave. So some of these alterations in behavior is the pacing, constant pacing, or stereotype behaviors. When we say stereotype, repetitive movements. You have automatic obedience. They're responding like a robot. Waxy flexibility, being maintaining a specific position for an extended period of time, being stupor, motionless for long periods of time, like one is like in coma, negativism, doing the opposite of what is requested, echopraxia. There is purposeful imitation of movements made by others. Catatonia. There is pronounced decrease or increase in the amount of movement. So like muscular rigidity, catalepsy. This can be so severe that limbs may remain in that position as they are placed. We have motor retardation, slow movement. You have impaired impulse control. The person just do things randomly. Gesturing or posturing, okay, something illogical, unusual positions. And then boundary impairment. The person cannot see where one's body ends and where another begins. So he will just walk and bump on someone. There is no personal space around this person. So as you can see, these are really bizarre thoughts and behavior which can bring harm to oneself and to others. Bizarre thoughts, like he thinks he's Superman, he could jump off the building, or there's no boundary with his body, so he could be like walking around like 24 hours, and this can cause a problem to the person. And so the first thing that we do is really control these symptoms by using these conventional antipsychotic medications. And what are the four common antipsychotic medications? You have your haloperidol, loxapine, chlorpromazine, flufanazine. These are actually to control the behavior. But take note, since it's trying to control behavior, one of its side effects is the extrapyramidal effects, which includes dystonia, akathisia, Parkinsonism, tardive dyskinesia. So we have a lot of terms here, but just take note from the word dystonia, dyskinesia. It's all abnormal movements, either too slow, too fast, uncoordinated, unexpected. Okay, so there are some reminders because of the side effect of these meds. One of the side effect are the anticholinergic effect. What is this anticholinergic effect? You know, dryness of the mouth. And so we allow this client to chew sugarless gum. To avoid constipation, eat food high in fiber, drink 2 to 3 liters of fluid, and this person can go hypotensive. So when this occur, we let the person lie down, okay? And when he gets up, we make sure he doesn't get up too fast because he can have orthostatic hypotension. Other drugs, these are your second generation. We have this because if first generation don't work, then these are your second generation meds, which can treat both positive and negative symptoms. So we have your risperidone, olanzapine, ketapine, ceprasidone, and clozapine. Now, these second generation meds can cause weight gain, so we help the client follow a healthy, low calorie diet, engage in regular exercise. There could be adverse effects such as dizziness, sedation, sleep disruption. And then we monitor blood tests because these second generation meds can actually affect the white blood cells, which can lead to a granulocytosis. Okay? Then other antipsychotic meds, you have your third generation ariprazole. Okay, so I'm just making you familiar of these psych meds. And of course, since the person with psychosis, the thought is really um, disturbed, we may need to give antidepressant to, regulate the thoughts. This is used temporarily to treat depression if there is depression or sad feeling, especially for clients who are suicidal. We would like to increase their self-esteem, okay, thoughts, so that but as I said before, a person who is depressed and we give them antidepressant, the moment they're feeling improved, they actually become risk for suicidal. Okay. And then that's why when we give our clients antidepressants, we cannot just abruptly stop these meds because we want to keep at keep the chemical level and maintain the mood in the client. Okay? Other psychotic meds will be your mood stabilizing agents and benzodiazepines. So examples are valproate, lamotrigine, lorazepam. So, what do we have to remember as a nurse? Previously, we talked about individual therapy, family therapy, group therapy. In other words, we're trying to change the environment of the client. We call this milieu therapy. Okay, so here we provide a structured, safe environment so that when everything is structured, it brings less anxiety and then less distraction as well. And then we involve the community. We call this ACT or assertive community treatment. It is a case management. There is an interprofessional collaboration to assist in managing the different needs. And of course, therapeutic communication, the way we answer the client based on his questioning or how we draw him out to reality. There is that therapeutic way of talking, which we highlight in the past, no asking of why, we focus on the emotions, okay? And still, Very basic. We have to establish trust with the client so the client will open up themselves to us. We use appropriate communication to address hallucinations and delusion. So we ask the client directly about hallucination. If the client is saying something, we nurses should not argue nor agree with the client's view of the situation. So if the client say, I hear people talking, they want to fight me or they want to kill me, we say, I don't hear anything, but you seem to be feeling frightened. So we recognize the feeling without recognizing the hallucination. So never argue with your client's delusion. Focus on your client's feeling. Maybe offer reasonable explanation that, for example, I cannot imagine the president of the United States would have reason to kill a citizen. That is when a client think there is someone or the president is up to kill him. But you say it must be frightening for you to believe that. So there is recognition of feeling. Now, if the client is experiencing hallucination, we provide safety. Uh, we attempt to focus on reality-based conversation. Okay, we do not build on the hallucination. We try to identify what could have caused that hallucination. Okay, so that we can bring the client back to reality. We also plan the discharge of the client because as much as possible, we want to bring this client back to the community. So basic nursing, okay, we get to see or and prepare what are the client's needs so they can perform their daily ADLs, okay. Promote self-care by modeling, teaching client about self-care, collaborate with the client to use manifestation management techniques so they can cope with their depression, techniques to distract from voices, walking, talking to a trusted person when hallucinations become bothersome, and being in control and able to say to the auditory or hallucination, stop, go away, trying teaching the client some coping behavior. Okay? As much as possible, we incorporate family in all aspects of care. Now, this last slide, you can see speed dating with psych meds. What does this mean? So let me open this slide. So here you can see it says Hobart Dating Psych Meds. Okay, so let me read and explain as we end what this means. It had been a long time since I sought something psychoactive. In high school, Lexapro was my perfect match. It worked for a while, but then it stopped, so I went off of it. After college, I decided I needed to be on meds again. So I was sleeping a lot and feeling anxious. But I knew it would be a bit of a guessing game. So the first medication prescribed was Effexor, but after reading the review, I was too scared to try it. Next, I tried Wellbutrin because it worked for my brother, but it made me unable to sleep and gave me a feeling of constant impending doom. Then I tried Lexapro again, but it gave me the spins. Now I felt discouraged. I was ready to accept that I'd feel this way forever. Then I decided to give one more prescription a chance, Celexa. I waited for side effects, but I experienced none. After a few weeks, I started feeling like myself again. So trying to find the right psych meds felt a lot like dating at the time, incredibly hopeless, but I'm glad I stuck it out and found my psychotropic soulmate. So, what am I trying to say is that finding the right medication to fit the psychosis of this person, to manage the psychotic behavior. It's not like right away we say this is the drug that fits. So that is something we tell our client that it takes a while to be finding the right match. It's like that's why we call it the psychedelic dating, and that's usually what happened with the psych meds. We call that speed dating with psych meds. Okay, so that ends our discussion on psychosis. And if you feel a little bit overwhelmed with the terms that is expected, we're not gonna be experts on this. We just want us in our nursing program to have already an encounter on the complexities of psychiatry and the psychotic disorders. Okay, that's it. Thank you very much. And I'll see you all on Friday.